welcome back to another episode of the Vitality Code Podcast. I am your co-host, Dr. Jeffrey Farrah, joined here by my well-educated brother, Dr. Jason Farrah.
So let me explain the look. Here we are podcasting on a Sunday because technical difficulties and hadn't had a chance to get my hair cut. So I got the Body Rev hat. Look at this, baby. I got the swag on. See? And you can see the hair. Look at the mess. And it
Better than mine.
Body Rev. Yeah. Well, not much. Thank God this podcast, thank God the camera is a face forward only, or else if it was from the crown,
I can't wait till
I
you
would
go
be
bald.
very
It's gonna be
follicular,
amazing.
follicle challenged. But yeah, and so I thought, this kind of ties in nicely. We're talking about the fringes of medical science, so to speak, a little bit, potentially, and maybe some stuff that interests the bro science folks out there. So I'll take that.
There you go. But in actuality, the stuff I want to talk about has
I'll look like a bro.
wide-reaching effects, and I find it more. Well, maybe it's just my clinic. I don't really deal with a whole lot of bro science stuff. Nonetheless, little disclaimer: the stuff that we're going to be talking about today, make sure you talk to your doctor. This is not medical advice. These are some in-office peptides that we use. Some of them are FDA approved, some of them are not. So make sure you know your source and make sure you talk to your doctor. Again, this is not legal advice. But with that quick disclaimer, Jason, what I wanted to talk to you about was the growth hormone peptides that are out there. I'm going to use that as a classification. We have insulin's a peptide. So people use this word peptide as a overreaching thing. I think sometimes what we mean a lot of times is a couple simple classifications that I see most commonly used when people use the word peptide. And one of the most, if not the most common one, are the growth hormone analogs, secretagogues, growth hormone peptides. These are some of the phrases that we use. So if you could tell me maybe the top few that you see and maybe a quick little difference, because I see these things a lot of time. People are like, I want to try testosterone. I want to try ipamorelin. I want to try the growth hormone releasing hormone, and they don't necessarily know. So maybe break those down into the biggest, most common ones that you see.
Yeah, so they're pretty popular, you're right. And I think part of it is, there was different. It depends on what peptide you're looking at, but in the 70s they started looking at these things. In the 1990s, it took up another surge in research. It seems like, from my looking back through the published literature, and there are FDA approved peptides, let's call them, which are growth hormone secretagogues, meaning they induce or stimulate secretion of human growth hormone from the anterior pituitary gland. They are not growth hormone themselves, and I think that's a misconception sometimes, but they do cause your body, the somatotrophs, which means cells that can produce human growth hormone in your body, to produce more of that. And then the downstream target for human growth hormone is IGF-1 for the liver. So you have to have an intact liver, you have to have an intact hypothalamus and pituitary gland, and the receptor sites have to be intact so that the drug can work. And there are disease states in which one of those three are not intact. So that's one caveat. But for the average, otherwise healthy adult or unhealthy pediatric patient, insofar as one afflicted by, let's talk, maybe growth retardation or short stature or, severe, they may take advantage of those in its FDA approved form, which would be like in the case of sermorelin, which was FDA approved for treatment of pediatric patients with short stature and those kind of things. In the case of lipodystrophy or HIV-associated lipodystrophy, tesamorelin is FDA approved for that. So for me, I think it's nice to have a general framework. Number one, these are not growth hormone. Number two, they induce growth hormone release from your brain. They are analogs of a hormone called growth hormone releasing hormone, or, this is a key distinction, growth hormone related peptide. And we're going to come back and circle back to what that means.
Let me interrupt you right there. So I think that is a good thing you pointed out. I think a lot of times the first misconception I hear is that people are like, I want to get those growth hormone analogs, or they say it differently, I want to get those growth hormone peptides, thinking that these peptides are shades of gray or hit the same receptors, or they are analogous with growth hormone, and that is not true, right? They stimulate the subsequent downstream effect of the release of growth hormone.
Absolutely, and that's a really key point. I'm glad you brought that up, because that needs to be understood by the patient. It needs to potentially be just briefly elucidated by the practitioner, because in the case of an older person versus a younger person, an older person's hypothalamic pituitary liver, we'll call it axis, because we're going to secrete HGH after first producing more of the thing that makes your brain secrete HGH. and then it has to go down to the liver to produce IGF-1. IGF-1 is the executor, HGH is the initiator. You have to have an intact hypothalamic pituitary and then target, in this case the liver, axis. So an older person may not have that axis intact just due to aging, so it may or may not work as well in an older person. But yes, these are not growth hormone analogs. These are growth hormone secretagogues. Yes.
Okay. So let's put those into categories then. So tell me maybe like which ones are the growth releasing hormones and which one major players. I know there's lots of fringe and things like that, but which ones are the growth hormone releasing peptides?
Growth hormone releasing peptides, right? GHRP. And those are natural, or those mimic the natural ligand. The natural ligand, so the word ligand meaning the binder to the receptor, the molecule that binds to the docking station and makes the effect. So the natural ligand is the ghrelin molecule. These mimic ghrelin. They hit the cell receptor in the anterior pituitary gland, but it's a different receptor. Meaning, if you gave GHRH analog and so if you gave GHRH analog, you get one spike in GH, okay? If you gave GHRP, you get a spike. If you put the two together, 1 + 1 = 3 in this case. You'll get an even bigger spike because they're working on different pathways, and you'll get an even more pronounced synergistic effect to create a bigger spike in the growth hormone, okay? They also have different side effects. For instance, let me give you the case of the three that we're talking about. The big ones are ipamorelin and hexarelin. There's a non-peptide mimetic that also does this called ibutamorin, also known as MK677. It's not a peptide insofar as it's not an amino acid sequence, right? It's a different molecule called a non-peptide mimetic, but it also does that. Hexarelin is much stronger than ipamorelin in terms of its production of a GH spike. However, it has the unwanted side effects of increasing prolactin and cortisol. We don't want these in our patients because in the case of prolactin, for instance, it has anti-dopaminergic effects. It has anti-testosterone effects, just for ease of understanding. And so while ipamorelin is not as strong as hexarelin, it has the best overall profile because you don't get the unwanted side effects. Ibutamorin has been actually well studied. It's a non-peptide mimetic, but it kind of got a bad rap in study of elderly patients recovering from hip fractures and other recovery scenarios. And in one study, it was associated with increase in CHF. And then those people it looked like it was CHF. It was actually due to hypertension, but was the hypertension due to pain from rehab, pain from fracture? Was it due to missing their meds? I don't know, but he got lumped in with that. And so it's kind of got a bad taste in people's mouth a little bit. So people kind of stay away from that. So on the one hand, GHRH, you're going to be seeing, we're talking about things like sermorelin, tesamorelin, CJC25 hits a different receptor or a singular receptor, a different receptor on the GHRP, growth hormone releasing peptide. And the best one there that in terms of effect versus side effect is ipamorelin. That's the most favorable profile. But there also exists other ones. Hexarelin would be a key example, and the older ones, GHRP2 and GHRP6.
Okay. So this is why we see the combination of, say, like a CJC 1295 mix with an ipamorelin, correct? Is you're both trying to get the downstream effect of the growth hormone to the IGF, but you're gonna stimulate the receptor from two different separate and distinct pathways, maybe getting a better response, or maybe, I don't know, you're just getting a more robust, more rounded out effect, I guess, or you're looking for a bigger effect. Do you know of any data that says you get a better effect when you do both as opposed to just one? I mean, I think
yes, there is data that shows that, and it's really nice because it highlights the enhanced pulsatility and enhanced peak amplitude of the GH spike when combining the two together. Now, where I like this is, let's take the example of CJC 1295, okay? And just for the listeners at home, CJC 1295, you may see it out there as CJC 1295 or CJC 1295 DAC, which stands for Drug Affinity Complex, okay? CJC 1295 was popular in the early 2000s when a company called Conjuchem from Canada was looking at it for therapeutic usage, and it went through phase 1 and phase 2 clinical trials. In the phase 2 clinical trials, it never made it to phase 3 because at least I read and I am told that the company ran out of money. The company is now defunct. It was not because of side effects, and you can look at the published literature and that seems to be consistent as well. There's a nice 2006 study in the Journal of Endocrinology and Metabolism from an author, a lead author, S.L. Teichman, 2006, if you guys want to look it up. And it was 2 separate randomized controlled trials. One took place in Miami, Florida. One took place in the Netherlands. Just to explain, DAC is a modified version where it makes the CJC, for ease of understanding, makes the CJC 1295 covalently bond to albumin. And that molecule, that makes us almost basically a separate molecule. It makes it such that the CJC 1295 has a much longer half-life. Instead of minutes, it's now days. So you can give a single injection once a week, and you'll see profound increase in GH secretion over the course of that week, for instance. In that study, at escalating doses, you saw higher and higher IGF-1 levels. However, the side effects became almost universal the higher you went. There were dose-dependent side effects, and they included things like local site reactions, erythema or redness, pain. Then those are kind of benign, so to speak, or small. But then things like headaches, loose stools, or diarrhea, which almost became universal the higher you went up. So you might desire a higher GH pulse to get better IGF-1 secretions or production to reach your target, but it comes at the cost of higher side effects. Well, what if you could get that same amplitude like you did in the study, but with a lower dose of CJC 1295? Well, you couldn't get it with just CJC 12 alone, right? Because the study showed that you need the higher doses. But if you paired it with a GHRP, i.e. ipamorelin, you'll get that peak amplitude, plus not using hexarelin, you won't get prolactin production, plus not using hexarelin, you won't get cortisol production. Okay, now we're talking. This is something that we can tolerate, it's safe, and we now get that desired peak amplitude of GHR release. But we're using an understanding of the physiology to our advantage. We're going to hit those cells at 2 different receptor sites at the same time to get the desired GH peak.
Meaning
That's
we're going to use the
is
ipamorelin to do that, a lower dose of CJC.
correct.
Cool.
So we're going to use the ipamorelin because it goes to the GHRP pathway. We're going to use the CJC to expose the GHRH pathway.
And so have you seen, or what do you tell people, or what's in the research, like why would I use CJC 1295 versus, say, tesamorelin? I think I have my way that I would maybe differentiate those, but is there a reason you would lean more towards one of those as opposed to the other?
Well, it can be as simple as something as what dose creates what effect and how much that dose costs. So the standard dose for tesamorelin is 2 milligrams a day. That's a big dose, man. Is it well tolerated? Yes. Has it been studied? Oh, yeah. It was a pretty good. It was in the late 2000s. I can't remember the exact time frame. In the 2010s, there was a study that came out in JAMA, I believe, or maybe it was New England Journal of Medicine, looking at HIV-associated lipodystrophy and the benefits from using tesamorelin. And they were statistically significant in terms of body composition, fat-free mass accrual, subcutaneous and really visceral fat loss, improvement of like a fatty liver that's associated with HIV lipodystrophy, all desired effects. But you had, one thing, of note, it was 6 months long, and of note, they're big doses, 2 milligrams. And that led, and this was part of the clinical trials or, phase 1, 2, 3 clinical trials of a medication that's now FDA approved for that indication called Egrifta. So one is a cost thing. Next thing is which one is more profound at increasing sleep. And that varies author by author. It seems to me that the CJC 1295 is a little bit better at that, but it really depends on the dosage you're using, how you're using it, other things that go around it. But for me, it's mostly a dose and cost thing, and synergy. What are the differences for you and what you see in the clinic and what you're using it for in clinic?
I think I tell patients, and maybe you correct me if I'm wrong, I tell patients maybe if we're leaning more towards weight loss, that we would include as a additional effect, we would lean more towards a tesamorelin as opposed to, say, a CJC 1295.
Well, I would agree only insofar as tesamorelin is the strongest of the GHRH analogs. One thing that I can't figure out, though, is that because of the dosage you're using, or is that because of its natural inherent chemical properties? And I've not seen that been elucidated by the literature. And that's the problem with a lot of literature is the way that the studies are set up and the fact that statistics can be massaged and manipulated, reported, like in the case of absolute versus relative risk. You might say, hey, your risk of whatever disease state can be cut in half by this drug. Well, the absolute risk of you getting it was only 1 in 1,000 over 10 years anyway. So now, or 2, now we can cut it down to 1, it was only 0.1, it's 1%. Right. Now it's going to be 0.5%. Well, we went from a tiny risk to an even tinier risk. So
So maybe the tesamorelin just leans that way in the literature, but it could be just due to dosing as opposed to in a more profound effect because of the dosing as opposed to the effect of the compound itself.
Potentially, but I will say in the study literature and what's kind of out there available to look at, it appears that as best they can tell, put them on a level playing field and not FDA indicated approval, because there is no FDA indication for CJC-25 because those clinical trials were never finished. But the tesamorelin is considered to be strongest. CJC-25 the second most strong, and sermorelin the least potent. So what I have noticed with GHRH is the stronger the compound, or at least the higher the dose, you move beyond just sleep into fat loss and into muscle gain. Because what I think is going on, and this is a theory, is that, and one of the things I realized when doing this research is that human growth hormone has a small increase in your improvement in sleep, particularly slow wave sleep, in the non-REM sleep stages, which is the deep restorative phase of sleep. And in fact, if you supplement with HGH through a negative feedback inhibition loop, you're actually going to decrease GHRH, which will, then decrease your GHRH secretion, which will decrease sleep potentially, because it turns out that GHRH is really the somnogenic molecule here. It has massive, profound effects on the hypothalamus and in the cortex on GABAergic neurons or receptor sites to promote sleep. Not so with HGH. It's actually the GHRH. So
yeah, I remember you telling me that. That's pretty. I don't think I even realized or made that connection. I was always looking at these compounds, these ipamorelins, tesamorelins, CJCs, sermorelins as let's get your growth hormone, let's get your IGF-1 up because that's where the benefit is seen. And then I remember you telling me, no, actually there is some independent benefit of these GHRH chemicals, the CJC, the tesamorelin, the sermorelin, independent of the growth hormone. There is some benefit for sleep, and so that to me was a really interesting connection that I just had not made.
Right. And if you look at standard protocols for this, there may be a protocol, for instance, for sleep. There may be a protocol for injury recovery, a protocol for body composition and muscle and athletic improvements. For instance, the muscle and athletic improvements protocol typically include tesamorelin and overall the peptides at higher doses, because they do seem to make those effects at higher doses, which makes sense because you'll need quite a bit of IGF-1 secretion. And again, hearkening back to the 2006 study, the higher the dose of the CJC and the higher the amount of IGF-1 that was secreted. If we're saying that IGF-1 is the effector for muscle and fat loss, which it is, then you make sense that you would need higher doses of these to get higher IGF-1 levels. If we're saying, and it is the case, that GHRH independent of HGH1 and thus independent of IGF-1 is a sleep promoter, then absolutely. So interestingly, what you were telling people in the clinic is actually right on. It's actually right on target.
And possibly,
except to say except to say maybe you could overcome that with higher and higher doses. But I guess per unit volume, perhaps the tesamorelin, again, because it's strongest, would be the best for muscle building and fat loss. But honestly, when you get to that level of differentiation, maybe you're looking at stacks and using them in combination, and I like that better. But just categorically speaking, yeah, I think what you're saying is actually right.
Yeah, and that's interesting because you're saying that the protocols for the say recovery and muscle growth may be pushing the IGF levels higher, but that may be counterproductive for some of the sleep benefits.
That's a really good point, actually. Yeah, and so you probably want to make sure you include GHRH
in addition
agonism
to, right?
Along with that, yeah.
Yeah.
Which I guess, again, tesamorelin is, but if you have another promoter in there to avoid the negative feedback from the HGH, would be a smart thing to do. And if you could do it through a different intracellular pathway, how much the better, right? So that's where you might include a GHRP ipamorelin. So just doing tesamorelin on its own, to me, seems like you're leaving cards on the table and might get yourself into a little bit of trouble from the sleep perspective.
Yeah.
Does that make sense?
Generally see better results when paired with ipamorelin.
Yeah.
I don't know that I had fully elucidated the reason why. And then you said something to me the other day about taking these compounds and understanding the difference between the GHRH and how those independently help sleep. And then maybe the GHRPs maybe less so independently helping sleep. And so maybe timing how you take those, knowing that clinical difference.
Yeah. And then, so yes, correct. Not only that, but the fact that insulin, not only HGH, but insulin will blunt the response from the pituitary gland when it is stimulated by GHRH or its analogs. Meaning, if you want to take these in a fasted state, so 2 hours, maybe even 3 hours after dinner, depending on how fit you are, what your insulin sensitivity is, or what your basal insulin secretion is, or your personal physiologic parameters. So 2 to 3 hours after dinner, and then you don't want to eat anything 60 to 90 minutes after taking them. So perhaps, and in the nighttime, it seems best to use the GHRH analogs, right? Because you want to promote sleep. GHRPs don't necessarily produce the somnogenic effects that GHRHs do, but they do produce the increase in growth hormone. So taking those in the morning in a naturally fasted state where it's not onerous to do, or you don't have to worry about timing. I mean, when you wake up, you have de facto been fasting. Seems to be the right thing to do. Plus, setting the stage for GH secretion would be things like, well, sleep helps because it promotes GHRH in a positive feedback way, but exercise does and fasting does. So those you're already set up. And so in the morning, you might go work out. So you've got the fasting state, you've got workout, you got two promotion, you've set the stage basically for these guys to work. Okay. Then you add in the GHRP, doesn't promote any sleep, so we don't nearly need it in the morning anyway. And it works again in the ghrelin receptors. It seems to be best to use in the morning. So I like using the GHRH at night and the GHRP in the morning.
Cool. Yeah,
reason.
I think that's a great. I don't think I'd ever thought of using them separated like that because I was always leaning towards just the growth hormone effects, right? So I hadn't really parsed out that these compounds independent of the growth hormone having individual effects that also could be timed, and you can maybe get the best bang for your buck by doing something like a GHRH PM and a GHRP AM prior to or post waking up and things like that.
Right. So in some so what we've highlighted here is reasons why it might not work, and I see this in the clinic sometimes, or certainly in my early usage, before I truly understood these things. So, what molecules are you using for what part of the day and night? What are you targeting? Are you targeting sleep? Are you targeting fat loss? Are you targeting both? Are you targeting muscle gain, etc.? Are the people taking them at the right doses? Okay, so they need to stick to protocol. Are you measuring IGF-1 levels afterwards? So patients really should understand it's a big commitment, like you've talked about. Don't do these until you're ready to do them, meaning you got to follow the IGF-1 levels, both so you see effect, and like in other words, if your IGF-1 levels stay below 250, you're not going to see an effect on muscle growth and fat loss. You might see an effect on sleep, but I don't think anybody is going to be sad about gaining muscle and losing fat. So then they probably want to have that. So make sure you're getting those target levels. And then are you timing it such that you're in a fasted state? Because if you're not, you're cutting yourselves off at the legs. Yeah. And you're not going to see the effect you want. So it's crucial.
Yeah, I think it's probably important for us as clinicians to understand that a little bit better so that we can apply these better. Because what I've noticed when I tell patients, like, what should you expect when taking these? It is not, in my opinion, I'll kind of get to what the research says. In my opinion, in the clinic, I don't see these maybe profound effects that some of the internet sphere has led people to believe will happen. It's not going to turn your bacon into broccoli. It's not going to take you from, it's not going to take you from Jeff Farrah to Arnold Schwarzenegger in 30-day cycle. So kind of understanding those, that there may be a limited effect. I generally use the phrase like it's icing on the cake. If you don't have a good foundation of hormone, if you don't have a good foundation of positive exercise habits, positive eating habits, it's not going to overcome all of those. Knowing that, though, if we have a better understanding of the research side of it, we could even maybe make those effects even better. So what does the research say about like what should we expect on effects, or what effects should we see from this upregulation of the growth hormone?
Well, the biggest three things are sleep improvements and lower doses, up to higher doses, seeing muscle gain and fat loss. And the muscle gain and fat loss are specific through HGH pathways, specifically IGF-1. So you really got to see that the you need to see restoration of the IGF-1 levels from something below 250 or whatever their basal level is to something in the 250 to 350 range. And you don't want to go to excessive levels, like let's say 500 to 1,000 range, because at those levels, it's thought to be risky. You could potentially, well, first of all, if somebody's going to be on these medications, they can't have any active cancers. There are growth hormone or IGF-1 sensitive cancers. There's about 9 of them that I know are specifically sensitive to those. Things like colon cancer, breast cancer, endometrial cancer, thyroid cancer, specifically the papillary and follicular type, prostate cancer, hepatocellular carcinoma, for instance. There's a list about 9 of them. And then once you've ensured the patient's appropriate to do that, you're going to say, okay, you should see starting immediately within the first week improvements in sleep. Next, over the course of a month to 3 months, you're going to see progressive improvement, assuming that the IGF-1 levels are in target range of fat loss and muscle gain, but not if those IGF-1 levels are not at the right levels. And those levels are at the right levels if you're doing it right, you're at the right dosages, you're doing it in a fastest state. For instance, you're doing it as prescribed. Are you kind of person that can stick to, and has the injection been given every night, or some people do it 5 days on, 2 days off for a cycling effect, maybe preserve the natural GH pulsatility of the hypothalamic pituitary target axis. If those things are all done correctly, and the patient says they have done them, then the IGF-1 levels are tested. If those are appropriate range, then you should start to see muscle and fat loss within the first month to 3 months. If they don't, or if they're not reaching IGF-1 levels, for instance, they have underlying liver disease, they have some kind of receptor site abnormality, which do exist. They're kind of rare, but those things do exist. And that might be something to look into if that's going on. But like you said, I think the first thing is laying the foundation. Have you built the cake before you put the icing on the cake? And that has to be diet and exercise. What seems to be the case, even for testosterone, is that these compounds, and I've said this before in the podcast, it's not what they do to you, it's what they can do for you. They can take your natural, biologically ingrained pathways and enhance them. But you have got to get those pathways rolling. You have to overcome the initial inertia to prime the pump, so to speak. And if you prime the pump, then the gains you'll get will be substantial and or exponential. If you don't prime the pump, they'll be moderate at best. And I'll give you a case in point that's in the literature. What I noticed in the 2000 teens study published in JAMA, New England Journal, on testosterone and HIV lipodystrophy is that the fat-free mass and muscle gains were modest. The fat loss was moderate. They were statistically significant, but they were moderate. The improvement in fatty liver, as determined by serial CT scanning or some type of imaging, I think it was CT scanning, was moderate. But what I noticed in the plan is that these people did not change their activities of daily living as best I could tell in the study. There certainly was nothing in the protocol that said they exercised a certain amount a day, they did certain diet, etc. It seemed as though, and it may have even expressly said this, that they just, whatever they were doing before, they went about their daily life otherwise the same. So there was no increase in exercise or any kind of dietary changes. What I have noticed, though, in studies in similar compounds, not these compounds exactly, although there are some in these compounds, if you do that, the gains seem to be way more than would otherwise be. So if you're looking for extraordinary gains, you need to make sure you've built the cake, so to speak, before you put the icing on it. Then that cake's going to be delicious.
I imagine for a study, I could see that. We want to see if the compound in the absence of exercise makes an effect, right? Because we're not necessarily, I'm trying to sell a compound, or I'm trying to prove a concept. But that also But that also misses like what we as wellness doctors do. Like I always tell patients, don't do this as a substitute for exercising. Do this in addition to your exercising. So what I might be more interested in as a clinician is, how does this work in addition to exercise, and how much better would the gains be with exercise or with diet changes as opposed to changing nothing? But I could see how that could be a researcher's
right. I would say
tilt.
I agree with you. Yes, I agree with you categorically, except to say that all you need to do is logistic regression analysis and make sure your control group's also exercising. Then they're putting everybody on a level playing field anyway. So it's really just,
there you go.
It almost seemed to be like lazy research setup. Let me give you an example. The tirzepatide study that came out in 2022, or whatever it was in New England Journal, was it? That definitively showed that Zepbound or Manjaro, whichever one, did improve statistically significant improvement in fat loss as opposed to the placebo group. Both groups did diet and exercise, very controlled, 500 kcals less than their normal allotted, 30 minutes a day, 5 times a day. And what was really cool was that in the control group, they had fat loss, and it was pretty substantial. It just was not, it was statistically significant less than the ones that use the drug. I mean,
Right.
quite a bit, but it was still, when I went back and looked at the data, I was like, you know what? Nobody talks about this, but this control group did pretty good too, which harkens back to what all the fitness coaches and wellness docs and people in the space are saying. Like, don't forget the important foundational principles, and then if you want to improve upon that, yeah, icing on the cake. I like that. I love that scenario you come up with.
I picked up on one thing you said when you were talking about the benefits of growth hormone, sleep, fat loss, muscle gain. Is that, did I hear you correct that you might see the sleep benefits at a lower dose, but potentially to get the muscle gain, fat loss, you might need to push into higher IGF scores, potentially meaning a higher dose, and that those improved sleep as a marker of success of the medication is not necessarily a marker of other benefits of taking these peptides.
100%. Because, and then that harkens back to understanding the physiology, which we're covering here.
And I don't think
that's
I
why we're covering it
always
for your benefit.
clearly understood that. I would tell patients one of the earliest things that you will see is an improvement in sleep, and that means that the growth hormone is starting to work and the other benefits will come. But that may have been wrong. That improved sleep could be at lower doses just from the GHRH effect, maybe not even from an improvement in growth hormone.
Yes, and in fact, I would say not maybe. I say at least according to what's known scientific literature is. And
so
that
what
is
levels
interesting.
of IGF do I need to get to? Is there some research, like I check IGF levels, so is there some research defined or better defined level of IGF that I need to push to see the fat and muscle?
Yes, and it's something, so that's an interesting topic because it's not super well defined, but it is defined. And I just want to add something in here too, is you see a lot all over the internet in clinics and everything, and you got to be careful with this. Taking HGH is going to improve your sleep and everything, and that might be saying, or they conflate peptides with their effect in secretion of GH and then ascribe all the benefits to GH when in reality it's the GHRH. I want to be very clear about this. The GHRH that has the somnogenic effects through GABAergic neurotransmission effects in the cortex and hypothalamus. Okay, so it's not human growth hormone. In fact, you could even say human growth hormone is detrimental to your sleep insofar as if you increase that and IGF-1 levels, you'll increase negative feedback, which means you'll reduce naturally occurring GHRH. So I would go so far as to say even that HGH should not be taken alone. You can make the case for that. I'm not saying that definitively, but you can make the case. Let me say it that way. You can make the case because you want to improve, you want to make sure your sleep's intact because we know the effect of sleep on longevity, right? And if you're taking HGH by itself, you are going to potentially disrupt your sleep architecture and or at a minimum decrease your ability to take advantage of GHRH's somnogenic effects. But to your point, the IGF-1 levels that you're targeting are something like restoring you to what is less than youthful to something that's youthful. So you're looking at something that's greater than 250 to 350, or excuse me, something that's within the 250 to 350 nanograms per deciliter level. And then maybe you go slightly above that, but you definitely want to keep it under, maybe something that's less than the 500 to 1000 nanogram per deciliter level, because at those higher levels, the thought is potentiality for inducing growth of cells that you don't want to grow, i.e. cancer, or because remember, we all have little cancers that pop up in our bodies, or at least according to science, that our immune system takes care of, and they never grow to full-fledged cancers. But if you had something in your body that could override that mechanism with making them grow faster than your immune system could keep up with, for instance, again, this is all theoretical, but you're looking, you don't want to promote GH-sensitive cancers, basically.
So speaking of the
those
side
being
effects and the
breast,
safety,
prostate, colorectal, lung, thyroid, liver, melanoma, ovarian, gliomas, things like that.
Other than
Sorry,
the
didn't mean
cancers,
to interrupt you.
what are some of the, I don't know, I don't want to say less significant, but I think we hear the word cancer, everyone freaks out, so I don't want to phrase it as less significant. But what are some of the other safety? Say someone wants to do these, we're using them in the clinic, some clinicians use them, whatever. What are some of the other growth hormone potentially related, if we're pushing higher levels, or just some of the safety of using these peptides in general, and maybe
Yeah.
not even related to growth hormone? What are the safety risk assessments, contraindications, other than
Well,
cancer?
sure. You're gonna you got to be careful. Certainly, there's AEs and SAEs. There's adverse effects, and then there's serious adverse effects. So adverse effects, something to know about and watch out for, could be site reactions like pain, erythema, or i.e. redness. Some of those have to do with the benzyl alcohol that they're dissolved in. For instance, in the CJC 1295 2006 RCT trial, there was at the highest doses on the order of like 200 micrograms per kilogram, if I'm not mistaken. Yeah, big doses. You saw big IGF-1 levels, but 100% of the people got loose stools or diarrhea, right? So not while that's not life-threatening per se, as long as it goes away, in the acute setting.
None of my clinic patients would want that.
Not something you want, right?
I
Yeah.
can trade that.
Right, or headaches.
You'll get the poops
Yeah.
for 3 weeks, but you can do this.
But you're
For
going to
3
be
months, I
ripped.
mean.
So that's one thing. One thing to be cautious of too is where you're sourcing the peptides from. What I have heard, interestingly, is remember, these are water soluble or created. These are not necessarily oil. Like, again, manufacturing of steroid or cholesterol backbone hormones has its own thing. But you got to watch out for LPS or lipopolysaccharide, which is the effector molecule in septic shock from bacteria, gram-negative bacteria especially. So some of these bacterial sources can get into the water supply used to purify the peptides and that kind of thing. I've heard about Huberman talking about that on his podcast, LPS. So you want to get it from a source that has third-party purity testing, so you know that you're actually taking what they said, and that is done in a sterile procedure and is a regulated lab that. Again, these are not FDA approved, but they are research chemicals, and there is some degree of regulation, as is my understanding, just not the typical one for FDA approval. But so those are things. Now, other effects with human growth hormone would be things like hypertension. Human growth hormone at high levels can be diabetogenic, meaning it can cause hyperglycemia.
Yeah, that's
So
the big
look
one
at
that I was
hemoglobin.
interested in hearing
Yeah,
about. Yeah, that's what I tell
yeah.
patients. Everything has a cost to some degree. We can't just do anything and everything.
There's no free lunch.
There's no free lunch.
I
Yeah.
always tell patients there's no free lunch. And so then the other thing is papilledema. So increasing intracranial pressure
I didn't know about that.
seems to be unique to HGH, yeah, and it can cause effects on the optic nerve, which is a direct extension of your brain, really. And so swelling and encasing you can get a compartment syndrome of the optic nerve, basically, and ultimately lead to headache and severe headaches, and then intracranial pressure increases, which have its own problems, devastating neurologic effects from that if it goes on. And then on the effects of the optic nerve, I guess in an ultimate case scenario, blindness. But now you're not going to see those at physiologic doses.
Right.
If you're working with a physician, in a clinic who understands and is monitoring your levels. But in an extreme sense, I don't know. I've heard of bodybuilders doing 15 IUs a day of HGH. I mean, just massive non-physiologic doses you're going to see. And then lastly, while not serious, but could be problematic eventually, and I have seen this in real world contacts or know somebody who knows somebody who knows somebody, see it on Facebook. This is sticking in my mind because I recently saw a guy who was this big time bodybuilder, just grotesque, and he just died recently, unfortunately. Went for elective surgery, which was, I can't believe somebody put him to sleep, and went apneic and then arrested, cardiorespiratory arrest during induction of anesthesia, which was really predictable if you know surgery and anesthesia, and then ended up on a ventilator and then ultimately died. It was sad, but or what I'm talking about is organomegaly. So anybody that has acromegaly, you'll see those type of, so people that have gigantism, which the medical name is acromegaly, they have GH secreting tumors from the pituitary gland, and they have massive stature, like Andre the Giant, for instance. They'll have diabetes, they'll have facial enlargement, big nose, big ears, big hands, but they'll also have internal organs like big liver, big heart, and those can have detrimental effects. So could somebody who stays on high doses of HGH indefinitely.
Yeah, I tell patients that's why we always take we always sort of hedge our bets. We always take an ounce of caution. I don't run these 24/7, 365.
Right.
We cycle on and then we pause.
Right.
Again, going back to my analogy of the icing on the cake, you don't eat icing by itself out of the carton, unless you're my children, but you don't
right.
Generally speaking, you don't just eat all icing. Yeah, icing's good, but you just a thin layer on the cake. You gotta have a good foundation. You have to have a good you have to go a place to apply it correctly, and we don't just run it all the time. So we're sort of hedging our bets against that. And the big ones that I think about for me, at least I've always elucidated, was the insulin resistance, and then potential of if we ran growth hormone secretagogues a long time would be organ growth. And I don't know
Right.
that to be 100% true, but I always want to lean towards the side of caution. That's why we don't run these all the time. I mean, at 365 a year. We want to preserve some of that.
Yeah, that's a good point. So they're true. That's a really good point when you said that. I don't know if it's necessarily to be true, but it's true. It's true and it's not true. It's true in the sense that if you push the boundaries and you theoretically could, if you can afford it, and if you could find someone willing to give you this, or if you found some kind of black market independent source or gray market, you could, assuming that you could get your GHRH to produce these wildly high levels of human growth hormone in your body, and IGF-1 levels were in the thousands for months/years on end. Yeah, you could, and so it's probably harder to than if you did HGH alone, for instance, because you're relying on that mechanism, which is kind of almost a nice thing about it, because your body has a natural feedback inhibition loop and it has natural checks and balances. So if you tap into the system and just enhance the system, you get a little bit of that de facto, which is nice, I think, and is a benefit to probably doing peptides, is that you are just making your body produce more of its own natural human growth hormone. And to really get those serious effects, you'd have to really push it beyond what most people could afford and or could.
I think that's the biggest thing. You can't afford. They're just not cheap because they're,
so expensive.
you know, I mean, everyone's like, why are they so expensive? I'm like, well, you think that they're popular, and you think that because you listen to Rogan, so your phone knows that. Then it taps you with 75 different ads from your Facebook, and you're scrolling through Instagram. So you think everybody knows about these peptides, and you think everyone's doing peptides. They are not that case. So just supply and demand. They're just not cholesterol meds in this world, right? They're not ubiquitously produced, and half the population isn't on them, and so the cost
covered
is
by
quite
insurance.
expensive. Covered by insurance. They're pretty expensive. So I don't even know that. At least I know my patients wouldn't be running these year after year after year just based on the cost alone.
Right, absolutely.
Cool, man. Well, that's been a good talk. I'm very interested in these peptides, and I always appreciate your scientific elucidation, your scientific inputs. It helps me in the clinical side of things. So if you're open to it, maybe we could tackle some BPC 157, which is something I like a lot in the orthopedic side of our clinic, and I use a lot, and I know the research stuff has always helped me. So if that sounds good to you, maybe that's our next.
Yeah, that sounds good, man. I'll meet you back here, same time, same place, and we'll dive into the world of body protection compound. I like it.
Sounds great. All right, buddy. Have a good one.
See ya.